Welcome to the third week of Pharmacology for Vocational Nursing 1. This week, there is a greater amount of content for us to cover, and therefore I've broken this presentation into two sections. Let's get started on the basic principles and concepts of pharmacology. Remember, pharmacology is the study of drugs. So what is a drug? A drug is any substance other than nutritional one that when taken into the living organism may alter one or more of the organism's function. How do these substances get into the body? Well, through ingestion, injection, inhalation, implantation, instillation, and insertion. The other way is that they get soaked in, or the topical approach. Let's talk briefly about the difference between pharmacology and pharmaceutics. Pharmacology, as you know, is the study of drugs, their origin, nature, properties, and their effects on living organisms. When we look at pharmaceutics, this is the act of pharmacy, the practice of compounding and dispensing medicinal preparations. This is focused on dosages as well as forms of drugs. This is a very specific science. So I ask you, why does the LVN need to understand these differences? So let's look at scope of practice. The scope of practice for you as an LVN is that you need to study pharmacology. You need to know the drugs. You're required to be able to do this to provide basic patient safety and safe patient care. Pharmaceutics, however, is the act of compounding and dispensing medication, and your scope of practice as an LVN does not include compounding or dispensing medications. You will not be creating medications either. Let's talk a moment about drug nomenclature. There are three ways that drugs are named. All drugs have all three of these names. You have the chemical name, which describes the drug's chemical composition, their structure. You will also have the generic name. Now, this is non-proprietary, meaning that no one owns it. This is the name given to the drug by the United States Adopted Council. Then we have the trade name. You'll recognize this as a proprietary name. It's a registered trademark of the company that manufactures the drug. Let's look briefly at an example. For example, here we have propionic acid, also called p-isobutylphenyl. This is the chemical name. You'll see that there is structure here. These plus or minus negative to negative show us about the bonds that are over here. The generic name for this, you'll recognize immediately, is ibuprofen. The trade name is Motrin. There are others, such as Aleve. They're also ibuprofen. When we look at the other areas to be discussed in pharmacology, we'll talk about pharmacokinetics with kinesia from the Greek, kinesia, meaning movement or motion. Pharmacodynamics, the dynamic is Greek, pertaining to vital force or the inherent power. Pharmacotherapeutics, from the Greek therapy or therapeutic, that is concerned with the application of remedies and treatment of disease. Pharmacognosy, from the gnosis, which is Greek, is knowledge or the study of drugs originating particularly in nature, those that we find in natural occurring minerals, plants, or animals. We have pharmacoeconomics, which explores resources and expenses of drugs. And then pharmacoethnicity is not in your textbook listing, but I want you to be aware more and more we are looking at medications in terms of ethnicity and the genetic components that can interfere or interact with drugs, as well as cause an enhanced effect. So, why do I point out the difference between pharmaceutical, pharmacokinetic, and pharmacodynamic? Well, when we look at how the drug goes from the dose of a formulated drug to the effect that it has on the human or the organism, you'll see we go through these steps. A pharmaceutical phase where the disintegration of the dosage form or the dissolution of the drug in the body occurs after administration. Then we have the drug available for absorption. This is then our pharmacokinetic phase, which deals with the absorption, the distribution, the metabolism, and the excretion of the drug, which renders the drug available. This is the pharmacodynamic stage, where the drug receptor interaction occurs, leading ultimately to an effect. So let's break this down a little bit further. Pharmacodynamics. There are two effects that we look at. I know in the beginning, last week, we talked about briefly that we would study biochemical effects and physiological effects. So what's the difference? Well, the biochemical effect is the effect of the drug at the chemical level. So how does this drug change the chemistry? The physiological effect is the effect of the drug on the function of the organism. So how does this drug change function? So in a very simplistic way, we could say that drugs act in 4 different ways. They replace or substitute a missing chemical. They increase or stimulate some cellular activity. They may depress or slow a cellular activity, or they interfere with the functioning of a foreign cell. Let's delve into this just a little bit further. When we talk about drug action, we're looking at drug receptors. The receptors are the component of the organism with which the drug binds to interact or change the function in the body. There are two types of drug receptor sites, agonist and antagonist. They were originally thought to be binary switches, so you either activated something or you turned something off. But now we know that agonists turn the switch on, so to speak, and antagonists block the receptor. The receptor is actually a continuous switch, so with its resting state being between on or off. So it's sort of like a key and a lock. What you'll see is that when we have the receptor, a normal response in a natural chemical, there's a very good fit of the key and lock. When we have an agonist drug, we get a mimicked response. It fits well into the key fits well into the lock rather, but the drug isn't exactly identical to the natural chemical. With an antagonist drug, what you see is the receptor site is blocked from soliciting a response. If we take this a step further, we could say that some agonists elicit a full agonistic response in the effect they occupy less than 100% of the available receptors. And then other receptors are called spare receptors. We could also have a partial agonist, and that means that there's only a slight chemical reaction produced because the drug attaches at the drug receptor site, but only in a certain way. Other ways that drugs can act are through drug enzyme interactions. We can have them as a catalyst, which causes a cascade effect. We'll start to examine this in more depth when we talk about anticoagulation, where there is a series of steps that occur. It's kind of like if you set up a set of dominoes on their end and you knock one down and they have this cascade effect. Then we need to think about selective toxicity. Some drugs are specifically designed with toxic, we know that they're toxic. It's the quality, the extent, or the degree of being poisonous. With selective toxicity, this drug has been developed to target a very specific receptor or site. Pharmacokinetics, then, is the study of the metabolism of drugs in the body with particular emphasis on the times for absorption, distribution, metabolism, which is also called biotransformation, and excretion. It's concerned with what happens to the drug from the time it enters the body until the parent drug and all the metabolites have actually left the body. So with this, we need to consider what's the onset of action? When does it start working? What's the drug half-life? How long is it going to be in the system? We'll talk about that in more detail. The timing of the peak effect. This is particularly interesting and important with some of our medications. The duration of the drug levels. How is it metabolized or biotransformed? And how is it excreted, or what is the site of excretion? If we look for a moment and step back, we also need to think about critical concentration. The critical concentration of a drug is the amount of the drug that's needed to cause a therapeutic effect. So sometimes in a situation you may need to give or hear of a loading dose. This is sometimes used to bring a therapeutic effect on more quickly. You won't see this as often in your practice as an LVN, but there are some clinics where you may give a loading dose of a medication. Then we also have the dynamic equilibrium. This is the balancing between the continuing processes of giving the medication, having it reach its peak effect, and then the half-life or the excretion of the medication. Both the critical concentration and the dynamic equilibrium can be affected by any of the steps of pharmacokinetics. Let's start with absorption. Absorption is how much and how fast the drug leaves the site of administration. It can leave through passive diffusion, active transport, or filtration. Here's a table that shows you a visual about drug absorption of various oral preparations. The fastest being buccal tablets or oral soluble wafers or an oral disintegration pill, with liquids being next, and then our slowest down here being enteric-coated tablets. When we look at factors that affect absorption, bioavailability, what is the formulation? Is it designed to dissolve? Is it fast acting? What is the concentration? Stronger is going to have a faster bioavailability. Is it lipophilic, meaning does it love fat? Is it acidic? If it's acidic, is it going to be altered if it gets into the gut where there's the hydrochloric acid? Also affect the route of administration affects the rate and the extent of the absorption. We'll talk about this more in a few minutes, but the enteral effects will go through what's called a first pass effect. The parenteral, the topical, and the inhaled, however, will not go through a first pass effect. First pass effect formula is listed here. However, you don't need to really recognize that formula. What you need to know is that drugs are administered into the GI tract, and they are the ones that are subject to first pass effect. Because the venous drainage of blood from most portions of the GI tract enter into the portal circulation, that delivers the blood to the liver. In the liver, and sometimes the gut wall, the drug molecules can be biotransformed. They can be metabolized to a less active substance. And the amount of active drug that actually enters the systemic circulation after GI administration of the drug is less. It's limited by the amount of the first pass effect. And so the magnitude of this you'll see is expressed in that equation. You will not need to know that equation. However, you will need to realize that any medication that you give through the enteral or GI route is going to be affected through the first pass effect. So enteral means the drug is absorbed into the systemic circulation through orally, sublingually, meaning under the tongue, buccal, sometimes pronounced buccal, meaning in that little pocket down in the side of your cheek, between the gum and cheek, rectally, sometimes, depending on the medication, rectal is considered a topical approach as well. The parenteral route is our intravenous. This is always going to be the fastest delivery of blood into the circulation. The intramuscular, the subcutaneous, intradermal, intraarterial, intrathecal, and that is in the spinal space, and then intraarticular, which is in the joint. Topical routes include the skin, the eyes, ears, nose, lungs, rectum, and vagina. Now we do have inhalation we also have that with the lungs as well. Distribution is the transport of the drug in the body fluid to the various tissues. Drugs are affected whether they are fat soluble or a water soluble. They're affected by the amount of tissue or the amount of edema that's present. We also will see areas of rapid distribution and areas of slower distribution. Here's a brief slide that explains to you the protein binding. Albumin being the most prevalent protein in the plasma, it's the most important to the proteins of the protein